Bismillah ar-Rahman ar-Rahim. Good morning, good afternoon, and good evening, my dear vascular and endovascular fellow. I have a great opportunity today to present one of the most eminent intervention radiologists, not just in the States or in Europe, but all over the world. His name is Professor Fakhir Elmasri. He has his university degree from Sudan. Then he went to United States, where he has built one of the best intervention units in intervention radiology. He has a large background in vascular surgical practice in the beginning of his career, but he has the clever end of vascular practice. He shifted right away to IR. He actually has invented a lot of the procedure, but he didn't want to put his name on it. I think he's the first one which have done deep venous arterialization plus so many ideas. I have learned so many tips and tricks from him, not just me, but a lot of the intervention radiologists all over the Middle East. He is a regular faculty invited in Perth meeting in Dubai every year, and we always see him in all eminent meeting with so exciting lecture. The problem that they put him presentation of 8 to 10 minutes, which could never summarize the huge amount of tips and tricks and he has. So here we present our first series of how I do it. Professor Fakhir Al-Masri. He's going to speak about one of the important topic for us as vascular surgeon, which we all have little experience with, which is pulmonary emboli. Professor Fakhir.
Yeah, thank you. Thank you very much for the generous, nice introduction. So we're going to be talking about pulmonary embolism. And as we all know, it kills more people than breast cancer, prostate cancer, lung cancer, car accident combined. So it's a huge problem. And we should be able, all of us, to contribute in trying to save lives in any way we can. So when I have a patient with a PE, pulmonary embolism, when they call me from the ER, the first thing I ask is the patient hemodynamically stable or unstable? That's the main thing you want to determine in making a decision. What's the definition of hemodynamically unstable? Basically, having the systolic blood pressure less than 90 for a continuous of 15 minutes. So a brief episode of patient just fainting, coming back doesn't qualify. It has to be a continuous 15 minutes of a systolic less than 90 or 40 points less than the normal systolic. So some people are already hypertensive. So if you're a hypertensive and say your baseline is 160, if you're 100 or 110, you're still qualified to be hemodynamically unstable. And that was going to divide the group into two. The second group, if you are hemodynamically stable, then the second thing is there an RV-LV ratio if there is a right ventricular is dilated. Do you see the slide, Mohammed,
Yes,
here
you
on
can
this?
see a slide. Yes, very clear.
Yeah. So this is an echo.
Yeah.
You measure the right to the left ventricle, and if the right ventricle is strained or dilated, then it is larger than 0.9. I call it 1. If you see the right ventricle and the left ventricle the same size, that means the ratio of 1, that means it's dilated. And that by itself is an independent factor for mortality.
Yeah.
I think I have a second slide here, which says the same thing. Yeah. So RV-LV ratio more than 0.9 is an independent predictor of mortality. So if you don't resolve this right ventricular strain, there is 8 times more likely recurrence of PE and 4 times mortality. So by itself, this is a huge determinant factor. You could get the RV-LV ratio by echo, or you could get it from the CAT scan. And we do a lot of CAT scan to diagnose them. So you don't have to get an echo. You just go and measure the RV-LV ratio on the CAT scan to determine that. The second thing you could know also the right ventricular strain is if it's leaking. If it's leaking enzymes, basically troponin, that's another indication that the muscles are weakened and it started leaking. So those are the two things I base my decision if I'm going to go in to
Yeah.
do anything or going to put them on heparin or any
Okay.
anticoagulation.
I got a question here from one of the attendee. What if you have accidental discovery of pulmonary emboli on CT scan?
Yeah,
Accidentally
and we see that
discovered.
a lot. Yeah, that's a good question. Many times we're just scanning patient for cancer and so on, and we see a bit of clot sitting there.
Yeah.
That's a good question. Again, we go back and see if there is an RV-LV ratio, if the
Yeah.
right ventricle is dilated, and if there is enzymes or not. Of course, the clinical picture is more important.
Yeah.
So, is the patient symptomatic from it or not? Because we have some patients, especially in the younger group, healthier, they could have a lot of clot and they don't show it. And you could have patients who are elderly with COPD and so on, who are huffing and puffing, but they don't have a PE or it's very minimal. So
Yeah.
the clinical picture in combination with so if you have a clot which is not causing the right ventricle to dilate and the enzymes are not increasing, you leave it alone. And we have a lot of those patients where unfortunately they wake me up at 3 o'clock in the morning. So I have to look at the CAT scan and so on. And the first question I ask, yeah, I see a clot there, but the right ventricle is not dilated. How is the troponin and the BMP? Just one point about the BMP is not as important as troponins.
Okay.
If the enzymes are not, the muscles are not leaking, the right ventricle is not dilated, that's a patient you shouldn't touch because benefit risk ratio is not warranted to
Okay.
advance catheter the heart to the pulmonary arteries to do
That's a
it.
very good point. Yeah. Thank you.
From that point, I think I have a diagram here which has to stratify if you have, yeah, over here. So that's an algorithm. Different hospitals have different way of doing this. This called here in the US the PERT program. It
Yeah.
doesn't. You don't have to have a PERT program. You just have to have a system, a pathway, where you're all in agreement. Well, the interventionalist with the ER, with the pulmonologist, with the intensivist, who are all on the same page to do it. So, as I said, the patient comes in. The first question is the patient hypertensive or no? Is the patient in shock or no? So if it's no, you go to the left of the graph. So this is intermediate or low.
Yeah.
If the patient is in shock or hypertensive, go to the right. And yes, this is a high risk. We used to call them in the past massive, submassive, and no massive. Now the criteria change into let me see if I could have a slide here. I think I have one here. The old classification, the new classification. Yeah, here.
Yeah.
So we used to call it submassive and massive and low. Now with the ESC, classification changed to high and intermediate and low. And the addition of the ESC in 2019, they divided the intermediate into two categories: intermediate high and intermediate low, which is very important.
Yeah.
Because intermediate encompasses a lot of range. And for years, for the past 10, 15 years, we felt that the intermediate has people who are really, really sick and people who are really not that sick, and they're all encompassed in one category. So the advantage of this classification is they split the intermediate into intermediate high, intermediate low. And basically, to make it simple, the intermediate high, you consider them high. You in all practical purposes, you would treat them as high.
Yeah.
And still there's no data. I'm sure there are going to be a lot of people who are saying you don't have data to treat the intermediate yet. And I use the word yet because I have 5 studies going right now. And that's going to be hopefully determined in these trials coming out. But so far, from my own practice,
Yeah.
we consider the intermediate high as high.
Okay.
And the intermediate low, we consider them low. So that line in the middle here is very important. And if you see here, they're all hemodynamically stable because obviously if they're not stable, you're a high. So the intermediate definition, you're hemodynamically stable. You go to the next one and you check for the classification of the PESI and simplified PESI. We're going to come to it in a little bit.
Yeah.
And then you come to the next one and you see the RV dysfunction, RV-LV ratio, which you could get it by echo, transesophageal echo or CTPA. And of course, the next level is the troponin.
Yeah. Excellent.
So let's go back. to the classification. So I'm jumping from one slide to the other, but
No problem. No problem at all. Yeah. This is the algorithm.
So this is a classification. So you follow this algorithm, and back to that same question you asked. The first question is, if you see a clot and the clot is sitting there, patient, you come to the left, patient's hemodynamically unstable. You do the CT angiogram, RV-LV ratio, if it's high or if it's normal. If it's normal, you go back and you go basically to anticoagulation.
Okay.
If the RV-LV ratio is high, then this is when you activate the system. Because RV-LV ratio by itself, as we mentioned, has four times the mortality rate. On the right side of the patient who are hemodynamically unstable, you do the angiogram or echo, and the same thing. If you come to the right heart strain, you call activate the system. And this is just so that they don't wake you up at 3 o'clock in the morning. You want to have the system, all the ER and so on, so that they basically stratify the risk and they filter the patient who needs help. Yeah. And then eventually you come for the intervention. Intervention, of course, is divided into TPA, either intravenous or transarterial or mechanical thrombectomy, which we do 100% of the time now.
Yeah, brilliant.
There is some, this, of course, the steps we went over.
Yeah.
Again, and then you determine what we spoke about. And then the second thing you look at the heart rate is a heart rate 130, above 130, below 130. Very important criteria.
Yeah.
And we went through the classification. And then you go through the relevant history. Some of the patient who had PE has history of PE. So they probably had a PE before and they survived it. And maybe treatment wasn't aggressive enough. So they gave some anticoagulation, the non-invasive way, and they ended up with chronic symptoms. Basically, the patient has CTEF or CTED.
Yeah.
So knowing that is important, because if you know that the patient has history and then we go and do a pulmonary angiogram and you find the pulmonary pressure is high, you remove the clot and the pulmonary pressure is still high. You're going to say, what's happening? I just removed the clot and the pulmonary pressure. So if you go in, you have to know if patient has history, because this patient probably has chronic post-pulmonary syndrome. That's the reason why the pulmonary pressure is high.
Yeah.
Of course, you want to know if it has an IVC filter or no, or stents, because you're going to go through most of the time through the femoral vein. You're going to make sure that the pathway is clear.
Yeah.
And and you want to see if the patient received TPA or no, or anticoagulation. I personally tell the ER, put all the patient anticoagulation. Just put a loading dose of heparin and have IV heparin on board. Of course, what we spoke about is the COPD.
Yeah.
Because that could make things a little bit contaminated. You don't know if this is from the COPD or the PE. We have one study showed a significant 1-year mortality for people who have COPD with PE versus without it. Okay. 61% and 31%. Of course, patient needs to be intubated or not. Because some patients get to they cannot maintain their pressure and oxygenation, and that's a very bad sign. Yeah. Once you intubate the patient, things go south. Yeah. I would rather have the patient not intubated.
Yeah.
Until I come in and take the clot out. Once I intubate, and general anesthesia make things worse. And then finally, and this is actually very, very important. I'm not a cardiologist, but the only thing I try to figure out on the EKG, if the patient has a left bundle branch block. The only thing, because if the patient has a left bundle branch block, that means the patient is dependent on the right bundle. And once you go with your catheter and you tickle the right atrium, patient goes into complete heart block.
Okay.
That is probably the only, and probably the most important thing in our talk today.
Yeah.
Don't try to put any catheter into the right atrium if the patient has a left bundle branch block, because you'll convert them into a complete heart block. And if that's the case, and as I said, this is probably the only EKG finding I trained myself to look at.
Excellent.
And
excellent.
If that's the case, call your cardiologist. They float a temporary pacer.
Yeah.
And it's very simple, take 5 minutes, so that if your catheter goes and tickles the right ventricle and the right atrium, they're going to complete
Patient
heart
spacing,
spacing. Yeah. So this is important. That's the reason why I have it in blocked areas.
Excellent. I got a question here. What do you do if the patient have previously IVC filter? How do you negotiate your catheter? Would you go from the arm, or would you still try to go from femoral through the IVC filter? What do you do?
Excellent question again. I did PE from the jugular. It is just not worth it. You have two angles. You're coming from the IJ. You have to make a sharp thing. You have to make a sharp. It's cumbersome. I would just go through you put your sheet. And the sheet goes, and all sheet you could navigate between the legs of the filter. So to answer the question, I almost do 100% of my cases through femoral approach, especially with the thrombectomy catheters. Now they're big.
Exactly.
So I don't want to. So I want to have a big vessel. I'll be able to go through, and you could easily advance your sheet, put a long sheet so that the sheet is beyond the filter. You could easily take it through the legs of the filter.
Excellent. And we always get the question with, what if there is a little bit of thrombus in the IVC filter? Well, the procedure is mainly to retrieve the PE. So even if you got a little bit of showering at this stage, it's not a problem. You can suck it out.
Yeah, you could do two things. You could suck it out on your way out. If it's completely blocking, but if it's not blocking, it's just at the cone of the filter. Just leave it alone.
Just leave it alone. Oh, brilliant.
Save the patient. Yeah, because what if you come in, that means the patient is really in trouble. And sometimes between the time we're coming in and then the patient has a full cardiac code is only 20 minutes, 30 minutes, half hour, to an hour. So those patients are really doing badly. So the best thing is just to try to go and relieve the PE. The question is, what if the patient has a clot in transit? What if the patient has clot in the right atrium? And that's a big, I don't know if you should answer this question now or later on, but that's something we are divided in that. This is there is controversy. In what some people say this patient is doing, because once there is clot sitting in the right atrium, the mortality goes high. That patient. So one of the things I said, that put that patient on ECMO. Don't even try to put them on the table. We do a lot of PE. So we are used to doing them. We got used to it. So we do it on our way up, but I don't recommend this for everybody. Unless you have like 50, 70, 100 cases under your belt to do it, because sometimes you have to have an echo so that you're visualizing the clot, because they have that clot is like a snake, just floating in the right atrium. And if that goes on the table, that patient is dying. So it's very, very high risk. So I take care of it before I go up to the pulmonologist. So I start the site, put an external echo, see how the worm is floating, and try to work on it, and then I take it out, because I'm think that the patient is still alive and the clot is not in the pulmonary arteries yet. Try to take it out of the equation, then and go to the lungs, because if that one goes, the patient's coding.
Okay.
But if you have an ECMO, probably that's a patient you could put an ECMO. At the beginning of your experience.
Excellent. Very good.
This again, the LeBron does how the Purkinje. So this is when you're dependent. When there's left bundle brown box, you're depending on here, and once this goes, the patient goes complete heart block. And this is some of the difference how to do it.
Brilliant.
Look at the difference between RBBB and LBBB. All right, so these are the lab values. You have to check your troponin. As I mentioned, BNP is also another criteria for cardiac strain. It's not as important as troponin. Lactate is very important. We are more and more looking at the lactate, because that's when patient going into cardiogenic shock. And unfortunately, none of the criteria we have today, if you're going to the PESI score or simplified or all of them, account for lactate. And I think there are going to be new criteria coming out, hopefully in the coming year or so, and lactate is going to be in the risk stratification, because you could be in cardiogenic shock with your blood pressure normal. That's another level of complexity, which we still don't understand fully yet.
Yeah.
And of course, creatinine and you have to check for hemoglobin, especially if you're using a device which is going to take a clot out.
Yeah.
Second thing also is like when you look at the CAT scan, you look at the. Let me play this CAT. So this is a CAT scan. Obviously, you see the clot.
See the emboli. Yes. You can stop it and put the arrow where you would like to. Yeah. Yeah. Here is the pulmonary artery. Yes.
Yeah, you see a cell from right to left, and then you go down and you look at the pulmonary. Obviously, this is very, very large compared to the left. So this is definitely. I don't have the measuring on this talk, but if you measure the distance from here and here, this is probably 1.5 or more. This is way more than the 0.9.
Yes.
Second, also important is look at the lung if there's any infarct in the lung, because if you have the lung infarcting, that means there is some chronicity. Didn't happen overnight, a while. And another criteria is we look for reflux. If you see reflux into the hepatic, that's another criteria of right heart failure.
Yeah.
And also you look for clot in transit. Clot in transit, I'm going to have another slide here where we talk about that. And the morphology of the clot, the amount of clot happening, because again, none of the criteria we have today account for the location of the clot. Is it central? Is it peripheral? Is there a saddle or no?
Yeah.
This is a CAT scan. You see the clot here, and then let me stop this image. You could miss. Yeah. I'm a radiologist, and I deal with a lot of diagnostic radiologists, and a lot of them miss it. Yeah. We miss clot in transit. Why? Because there is so much contrast sitting, and you could easily miss clot right in the right atrium. See?
Oh, yes. Yes.
People always look at the pulmonary arteries, and you miss the SVC.
Yeah.
So this clot is sitting in the SVC. I'm going to show you another. This is
yes.
This patient has thrombus here.
Yes.
Do you see the clot in the?
Yes. Very clear. Yes.
See it here, and usually it's like a snake. I always call it a snake because where did the clot come from? Came from the femoral vein, or we used to call it in the old days superficial femoral vein. So it's a long worm, and you see it folded itself sitting here.
Yeah.
And I'm telling you, a lot of people miss it.
Yeah.
So this is on the axial. This is on the transitional.
Yeah, that's good. Yeah.
See here? Of course, if you have an arrow doing this for you, you're going to find it easily.
Yeah, that's true. You rely still in diagnostic radiology, not in AI, to diagnose such a PE, because it usually doesn't miss any thrombi. Or do you do it up till now just by experienced radiologists? They reported for diagnostic.
Yeah, AI is still going to miss it. Yeah, it's going to miss it. It's
really?
Going to pick it.
Yeah. Good.
So you see the snake?
Yeah.
You always look at, and many times you have to play with the window of the CAT scan, because sometimes the window is too dense and the contrast. So you have to widen the windows, on your system, and you look deeply here, because if you see this is a problem. Yeah, and it's not that uncommon. As in this, they show the incidence between 4 and 18. Yeah, if you take the average of this, is about 12. Well, that means in every 9 patients, you have a patient who has a clot. And that increases the in-hospital mortality by 45%. Excellent. So be very careful. Those patients, the patient who you take to the lab and patient who die, there are probably a big percentage of them had clot in transit. Yeah. Okay. And of course, when you put on this projection, you see it even better because you see.
Yeah. Well, I got a question here. When you get someone with chronic with previous pulmonary infarction, does this make you think is that even if you retrieve most of the thrombus from pulmonary artery, the pressure will not be lower down in pulmonary artery? Does this, or what does chronicity, chronic pulmonary infarction mean to you as an interventionist?
That's another excellent question. Two things.
Yeah.
Number one, what you said. If I take the clot out and the pressure drops by a little bit, I won't be surprised at what's happening. You know what I mean? Because I know
Yeah.
this is his or her baseline.
Yeah.
It's not going to drop to. Second thing, which is also more important, when you have an infarction of the lung, that lung is soft.
Yeah.
So be very careful with the tip of your wire.
Yeah.
The tip of the wire could go and puncture because it's not a living tissue. Living tissue, you could go through it, come back, maybe if you bleed a little bit, who cares, it's going to heal. Necrotic tissue, you go with your wire. If you're aggressive, you go with your wire, and then you have a bigger problem in your hand now.
Yeah.
And the patient accepts.
Yeah. So you always want to see the tip of the wire during the whole procedure, especially if someone with previous pulmonary infarction.
Exactly. Because usually when we're afraid of perforation, usually it's in the lingula.
Yeah.
If you check statistics, people who don't have any infarction, healthy lung, most of the people have a puncture without me telling me. If you come and say, hey, I have a case which I had a perforation, I will just guess that was a lingula.
Yeah.
So that's where problem.
Yeah.
And I always tell people, be careful of the lingula. But if you have a patient who has a pulmonary infarction, I always be careful what the infarction is.
Yeah.
So if it's right lower, whatever, be extra. You have to be extra careful anyway. But be extra careful with the tip where the infarction is. Those are two things if you see a pulmonary infarction.
Excellent. Excellent.
So basically setting expectation, the patient and the family. TPA. If the patient is too unstable to move from the ER, I tell them start your IV TPA. Yeah. IV TPA is not replacement for my thrombectomy. It's just for the patient to be alive until I'll be able to take the clot out, because it takes me half hour to make it there, another half hour to do the procedure. So patient has to survive for an hour, even if they're basically crashing or in shock.
Yeah.
And this is again of the pulmonary infarction. In this case, this CAT scan is going to show clearly there is a pulmonary infarction in the apical right lower lobe. And so when I'm looking for a PE, I'm not just looking like this patient has.
Yes, very clear infarction. Yes.
You got to be careful of those.
Yeah.
Risk of hemoptysis, and as I said, consider avoiding wiring in the area of the infarction, because what's going to happen. And the second also about the chronic clot, since we're in that topic, the shape of the clot is different. Like look at it. Clot doesn't look like that. This is adherent to the wall. Usually the clot is like a sausage sitting within the lumen. Yeah. This even without getting any history, clot doesn't sit there. Clot doesn't sit in that location. Clot sits like a back and a saddle, like what we saw in the previous cases. Yeah. The morphology of this is a chronicity. Okay. And sometimes the markers will be negative, because the patient got used to that. And it's the word we use is eccentric. Okay. Yeah. And what happened in this particular case, I'll show you where they perforated. And if they perforate, be careful. You have to have a balloon, and you have to go and shut the area you perforated with a balloon. And sometimes I don't have the case here, but you have to go and coil it. Okay. I have a case here. I remember. Oh yeah, here. So yes, I can see the coil. This is this wire wasn't too careful when it was, and then this is a lot of coil. This is like probably like $20,000 of coil. Yeah, yeah. Very expensive for this amount of coil, but this is a life saving, because exactly this patient died as iatrogenic from your procedure. And
if you inflate the balloon, how long do you inflate it, and do you use the in the old era we did have the golden detached balloon, but I don't think there is detachable balloon anymore in the market.
Yeah, that's out. Yeah, usually that's actually that's a great thing. You could detach it because they don't manufacture them anymore
Yeah.
because the usage is very, very low. So you just put the balloon and wait
And wait, yeah. Temporary blockage. Yeah. Good.
yeah. Um, Second thing also, this is a lateral view
Yeah.
of the basically a sagittal view, and this is the right ventricle. And when you go, this is what we call the right ventricle outlet track
Yeah.
here.
Yeah.
Your catheter is going to be sitting here. Just you have to be fast. So especially if you're using large bore, you have to be fast because the pulmonary artery is already compromised. Patients depending for a little bit of blood flow. So your catheter is going to be occupying some of that space.
Yeah.
So you don't want to be there for a long period of time. Second thing, you don't want to do pressure. You don't do the plunger, the pressurize. You do
Yeah.
hand injection.
Yeah.
Contrast places the little blood of flow going. And here, I just always tell people that the average diameter here is only about 15.2 millimeters. So you have a big catheter sitting, they're taking a lot of. So sometime after I do suction, I put my catheter back into the cava, wait for like 60 seconds for the heart to breathe, and then
And
go
then
back
you go
again.
in again. Oh, that's a good technical tip. That's really good technical tip, because you're absolutely right. When you stay with a caster, it's now what 6, 7 French is the one that you use for PE in this space.
Depends. If you're losing large bore, it could go up to 24. And 24 French, you divide them by 3. That's about 8 to 9 millimeters.
Yeah.
You're already buying 50% of that lumen.
Yeah. Yeah. That's
So,
true. Okay, I will freeze here. Yeah, you can continue.
yeah.
Yes.
Yeah, so we'll talk about the what we call the right ventricular outlet tract,
Yeah.
which is over
Yeah.
here, which is said is 1.5 centimeters. So the bigger the catheter you have, the more careful you have to be.
Yeah.
So if you're using the 24, the Triever 24, which I use a lot, it's a good device.
Okay.
Be careful that keep your wire in, take your Triever out, and go back again because it's this is where people get into trouble, especially if the patient is already hypertensive and crashing.
Excellent.
Any questions?
Yeah, we have a question. What type of catheter and device do you prefer in pulmonary emboli? And is there is difference between any of these types that you used?
I use all of them,
Okay.
and there are lots in the market. Of course, every country and every hospital and every contract are different, even in the United States.
Yeah.
So different hospitals will have different contracts and so on. But we basically divide them into basically chemical versus mechanical. Chemical, basically, you put a catheter and you drip TPA. This is how we did it since the beginning.
Yeah.
Actually, even before that, during my fellowship, we took a pigtail catheter and just went and tried to break it with a pigtail catheter. That's all what we had.
Yeah.
And then after that, we tried to macerate it with a balloon because we didn't have anything. Patient is basically are dying and they need gasping for air.
Yeah.
The device we started using at the time was the angiojet.
Yeah.
Angiojet. And angiojet has a black box warning: do not use in PE. It's very written clearly. You're not supposed to use it.
Yeah.
Because it has that vibration and it causes arrhythmias and cardiac arrest.
Yeah.
But since we didn't have anything else to deal with, so basically we tried to stabilize the heart by a minophyllin or theophylline IV to make the heart less sensitive, and we went and did the angiojet.
Yeah.
And that was early. That was 2007,
Yeah.
2006. There's nothing else. And then after that, we had devices off-label use, basically to macerate the clot. So we took devices which is supposed to be done in AV grafts. Yeah. Like Teratola, we use the cleaner, we use devices to break clot elsewhere, and we use it to kind of macerate the clot. And one of the things which are also important, even if you can remove the clot, even if you fragment it and push it farther out, you improve the flow
Okay.
because you are taking from the main pulmonary artery, which is shutting everything, and now it's going distally. So, and that's what he had.
Okay.
And then after that, we had catheters and we put TPA and we ran them overnight in the ICU, just simple catheters. And then echoes came out. So we're doing echo thrombolysis, which is an ultrasound fragmentation. And then after that, catheter started getting a little bit bigger. So we had the catheter we used from Penumbra, which was basically it was a neuro company. So they had little catheter in the and then they started to a 6 French and an 8 French. And an 8 French now is laughable. If we look back, we're using just an 8 French. But that's all what we had. And we worked, it has a separator wire, put it into pulmonary fragmenting. And actually, we saved life with it.
Yeah. Okay.
Then the 12 French came out, which was a huge thing.
Yeah.
Also, we went in fragmented. And then Inari came out. And Inari came with the big one. So they started with the 20 French. And then after that went to 24 French. Yeah. And that was revolutionary.
Yeah.
Because now we're in large amount. You just have to be careful of this, what we mentioned here with that size. We saved a lot of lives with them. Just have to be careful a little bit.
Okay.
Big size. And then after that, Penumbra came with a 16, what they call the flash.
Yeah.
Which is advantages. It's lesser in diameter, 16 from 24. And it has equally powerful technique. And there is every week or two, there's a new company coming out. We have Imperative Care came out. They have a 20 French. We have Argon. They come with a Cleaner Plus, which is an 18 French.
Yeah.
It's being used in the legs, but is going to get a P indication. So anyhow, there are so many devices coming out, but the key is more the technique, more than what, because you could cause damage if your technique is not good.
Yeah.
And that's going to bring me to the next point is how to cross the heart.
Yes.
And that's a very important topic.
Yeah.
So I'm going to go here step by step.
Excellent.
How to do it. So number one, obviously, you use ultrasound to gain access into the vein. Because number one, it's simple, it's one stick.
Yeah.
Especially if there's DPA, on board. Second of all, you don't even know if the vein is patent.
Yeah.
You know what I mean? Because you could have a patient have a PE, that means it came from DVT. Maybe the common femoral vein is thrombosed.
Yeah.
Maybe the right side of the thrombosed, you have to stick the left side. Maybe both of them are here, you have to go into the jugular. And sometimes I go through a clotted vein, but IV is, ultrasound, I think, in my opinion, sticking a femoral vein or a femoral artery or anything, I think without ultrasound in 2024, we're getting close to 2025.
Yeah.
I don't think it's medically right.
Yeah, absolutely.
I think people should be capable of doing it because sometimes the ultrasound could be broken and so on. We should still, it's a difficult equation in retaining our ability to stick an artery without ultrasound versus, having
absolutely. Very wise.
Yeah, so definitely they have big sheet and so use ultrasound to gain access.
Okay.
Second of all, that's a question started with is you do a cavogram, an iliac. So you always inject contrast and do an iliac venogram because you don't know if there's a clot sitting in the iliac vein, or you could have a big torpedo sitting here, or you could have an IVC filter.
Yeah.
So you always, before you shove a big catheter up, always do a venogram.
A venogram.
And then catheters. So there are many ways of crossing the heart.
Yeah.
We are old-timers. We use the traditional techniques, and traditional techniques are very safe and very good. We cross it with pigtail. So there are two types of pigtail. You have a straight pigtail, you have an angled pigtail.
Yeah.
So some angle or the Grolman. And of course, there are people which I tell them they cheat. People who cheat, who use Swangans. Swangans is easy. You inflate the balloon and balloon floats in.
Yes.
It just costly. This costs like hundreds of dollars. $700 for Swangans. To me, it's a waste of money to use a Swangans just to be able to cross a heart. I think you should be able to cross a heart with a $20 catheter. You don't need $700 catheter to do that.
Yeah.
And something important here when you're crossing the heart, you have to be very, very careful of the chordae tendinase, because those are what we call the heart strings. That was attached the valve.
Yeah.
And in the old days, when we used to use echoes or TPA, I'm sure we went through the chordae tendinase. Nobody cared. Didn't make a difference. You go through it because it's a 6 French catheter. You drop TP overnight, you're fine. But now we have 16 French, we have a 20 French, we have a 24 French. You will rupture this tendinase and going to have death on the table or heart failure.
Yeah.
So you're going to be very, very careful that you went through the valve. You didn't go through the
How do you know, is your catheter tangled in chordae D or not? Do you know by the movement of the catheter, or you do echo? Because sometimes you don't get a certain feeling of, are you entangled in the chordae D or not?
I'm going to show a technique that's going to be 100% proof that you would never go through the chordae tendinase.
Perfect.
Okay, just if the pigtail is formed, the pigtail will never go through a chordae tendinase. So you form the pigtail, how we show here in the video.
Yeah.
And you turn it around and you go through into the right ventricle. This is 100% proof that you can never ever go through chordae tendinase.
Brilliant.
The chordae tendinase, you're going to go it only if you go through a wire.
Yeah.
But the pigtail tip is about 11.5 to 12 millimeters when it's formed.
Yeah.
So this technique, it's 100% proof that
excellent.
You're going through it.
Any specific curve of the pigtail? You just use the normal curve?
Just a pigtail has a circle.
Yeah.
Pigtail has a circle. The question is, because you need some maneuverability, you need to be able to change it around. So you could either use the angled, there is a pigtail which I go back here.
Which is angled one, yes.
And an angled one. If you don't have that one, I use the angled one because I could actually turn it around and go up.
Yeah.
If you don't have that one, like one of my partners, and I used to do that also myself, you take the regular pigtail.
Yes.
So regular straight angle. If you don't have an angle, you could take the straight one. Take the back of the wire.
Yes.
Which is a bend side. Make the back of the wire angled, but you don't stick the back of the wire through the loop.
Yes.
So if you see the back of the wire is coming here. See that?
That's a clever idea. Yes.
You keep it there. Don't, because it's very traumatic. You don't take it to the loop. You take it, and then by doing that, you have the maneuverability to put it up.
Excellent. Excellent tip and tricks. Fantastic.
Yeah. So again, you're going to see the back. When the back of the wire comes in, it has that angle.
Yeah.
And then you keep it there. Just maneuver it, and you're up.
Brilliant.
So those techniques. Obviously, always open a Swan-Ganz. And Swan-Ganz is another proof. The balloon will never go through it's too big. You inflate the balloon. To me, even in the United States, we have all the devices. We try to save money.
Excellent.
I'm sure, it's a waste of money to open a whole Swan-Ganz just to be able to cross. And the second thing also, if you are in doubt, always take it out and go again. There's no doubt. I remember a case very vividly. This patient, I did the loop technique. I went up. I put short tip amplas. We're going to talk about the stiff wire replaced.
Yes.
In a little bit. And then I was advancing my sheet, and the patient has, and this is advancing when you do procedure under local anesthesia. The patient had a lot of pain when I was pushing. I immediately stopped. I was 100% sure. But guess what? I took everything out and started again from the beginning.
Excellent. Yes, that's a good advice.
Yeah, if you're pushing and you're stretching those, the patient will tell you, they feel a lot of pain about that.
Yeah. I had this feeling. There was once I have an embolized stent that was in the right ventricle, and I have to snare it. And this is a different ball game, because when you snare it, you can snare one of the chordae D. I've done it under local, and every time you try to little bit pull, he feels severe pain. I know that I have chordae D entangled with it. So I've just touched the stent, and on the third time, I think, patient didn't feel any pain, and it went smoothly out. And this is when I know that I didn't entangle any of the chordae D. But I'm sure if I pulled strongly, would have been death on table.
Yeah. Local anesthesia is a blessing.
Yes.
Even say you're doing a venous recanalization.
Exactly.
Say a patient has chronic occlusion of the iliac veins. I'm trying to balloon. The patient will tell you. They always give you feedback.
Exactly.
I'm feeling pain. You know?
Exactly.
Say you're sending a CTO of the common iliac artery.
Yeah.
You're crossing. The patient is feeling pain. Sometimes when the patient is screaming in pain, I know I rupture the vein. Sometimes I'm calling for a cover stent.
Yeah.
Before I shoot the angel.
Exactly.
I know this patient ruptured something, and I see, of course, the what we call the Hiroshima.
Yeah.
But at least I have the cover stent coming in the way.
Exactly.
You are mobilizing, getting the blood.
Exactly.
So getting that from the patient is
I like the beauty of the protection of local anesthesia. I like it also very much in aortic stenosis when you're deploying a stent. If it is not self-expandable, if it is balloon expandable, when you're doing it under local, a lot before you get any dissection, patient feel a lot of pain. If you stop at this stage, and I remember many of the stents that I left only 50% deployed because patient feel pain. If I go any further, I would rupture. I have never ruptured either aorta or dissection doing it under local anesthesia. If patient doesn't feel pain, you are going all right. That's a great advice clinically, I think.
Yeah. I love local anesthesia. The patient it's a little bit discomfort to the patient, a little bit discomfort to me, obviously.
Yeah.
But general anesthesia, although it's more comfortable to the patient and the interventions, but it takes away a very important feedback.
Excellent. Because I learned a lot of tricks from you, and you are really excellent clinician. Before going intervention radiology, some intervention radiologists doesn't have this high clinical sense of management. They just let us say eye stent effect or something like that. But to have a clinical wisdom during your procedure is extremely important. And that's why the beauty of this lecture. Yeah.
I'll tell you also, because you also have a huge clinical, because we train in developing countries.
Yes.
And when you're in a developing country, you have to depend on so many feedback.
Yes.
Because you don't have all the, you know what I mean? So I remember you just mentioned about a case. One day I was doing a recanalization and I felt the tugging and I felt the patient screaming pain.
Yes.
And patient grabbed. And when you rupture in the venous side, arterial, you have a lot of muscles and tissues around it. Venous side is horrible if you rupture an IVC.
Yes.
So I just the examination, I knew things are really going bad. And I looked at my nurse. I said, "How the vital?" She said, "The vital is normal because we don't have an A line, so it doesn't."
Exactly.
You have
exactly
the pressure. So the first thing I did, I took my gloves off and I went and looked at the conjunctiva, the eye, because that's how I was trained from surgery, and it was white. I know this patient hemoglobin is 4. So I was like, started screaming, give me negative blood, even before the pressure, even before the patient crashed.
Excellent. Yes.
And things were moving.
Yeah.
And then in 2 minutes, the nurse said, "Oh, we have no pressure. We have so and so." So it's important for us who worked in when we didn't have all the facilities and so on. Depend on looking at the patient. Depend on looking. I could know the level of the hemoglobin fairly good without needing to send a blood test.
Absolutely right. Yes. This is a clinical sense that we're really missing with the young generation, because a lot of hospital now have total body CT scan before you come and see the patient, and this clinical sense, which is sometimes urgently needed, are missing. I'm not sure how you can train your juniors, but this is a very good lessons of how clinical sense of intervention radiologist and the surgeon are very helpful tool.
Yeah, before you retire, please pass all your experience to the youngsters. Okay?
Yes, that's good. That's what I'm doing with this series. I'm getting the expert to tell us all the tips and tricks, and I like your tips and tricks extremely well, because it works not just in the States but in the Middle East, in many countries, and it's a wealth of experience of really you summarizing to us a huge tips and tricks how to go safely and how to get a good outcome. This is very important. Please carry on.
Remember how we're trained that your physical examination starts from shaking hands with the patient, right?
Yes.
You're checking the temperature, the
Yes.
grip, how sweaty, how clammy.
Yes.
So we have to have now everybody's getting an MRI and a full body CAT scan and
That's true.
1,000 different blood tests.
That's true. That's true. Okay.
One thing I'm gonna put here before we end the talk here is the shape of the catheter.
Yes.
That's another important thing. It has to have the S-shaped catheter. You have to have that sigmoid way, because even before you inject contrast, if your catheter did not from the IVC, right atrium, right ventricle up to the pulmonary artery, it does not have that S shape,
Yes.
then there's a major problem.
Okay.
So look at the S shape here. This is not an S shape.
Yes.
This does not that come and down. And watch out for PFOs.
Yeah. That's right.
Pulmonary valley are very common. The incidence are between 10 to 25%.
Wow.
So make sure, because if you cross, you don't have the filter, the lungs, you're onto the left side. A single bubble is a stroke.
Yeah.
Make sure of that.
Absolutely. Yes.
So here, before you even inject contrast, you know there is something. You could go to the coronary sinus. If there's any problem, you take it back. And of course, you went back to the proper shape and now you're safe.
Excellent.
But
How,
even if you need
how you are sure that you are in the pulmonary artery? What tips and tricks do you do? Plus S shape.
Eventually you're going to inject contrast. That's how you're going to know.
Okay.
But if you look at this video from the beginning, this doesn't look.
Yes. S-shaped tool.
When you inject contrast, just make sure when you're injecting contrast, you do not have bubbles.
Yeah.
That's important.
Yeah.
Because if you cross here in a coronary, but say you're in a PFO. So if you're crossing arterial side, any bubble it's a stroke.
Stroke. Yeah.
So make sure and of course, if you see here, contrast has been injected.
Yeah.
But when you inject contrast, you're going to make sure you're injecting without, of course, to come back and you go back to the.
You can have multiple trials. Yeah.
Exactly. You see the S shape, you see the technique, and you inject contrast, of course, and you're going to know
That's a very good lesson. Very good lesson. If you're missing the S-shaped, go back and have another go, and unless you're comfortable. Yeah.
Yeah. Look at the right side. There's no S shape. You just make that.
Yeah.
That's you're going to inject contrast. You're going to know.
Yeah.
But just make sure you don't have contrast.
Okay.
Or of course another complication. I don't know how they do it. Pericardial tamponade and crossing into. So you could cause a lot of damage.
Absolutely.
Just by simple thing. Yeah. So we have a saying here when people talk about tools, which tools you have and so on. And we have a saying, we say, a fool with a tool is still a fool. So
yes.
It's not about the tools, you know what I mean? Tools will never make people better interventionalists.
Absolutely right. This is a great lesson. A great lesson. A high-tech tool does not make you intelligent. And you must have this cleverness, whatever you will use. This is a great lesson. Yes, please.
Yes, stick to the basics.
Yes.
I always tell people.
Yes. Absolutely.
So again, talk about this. Do not inject. Don't use a power injector.
Yeah.
This is different. There is an Amplatz wire.
Yeah.
Which has a short tip.
Yeah.
So the Amplatz usually have about 7 millimeter floppy. The problem with that Amplatz, let me find an image. When you're in the pulmonary artery, let me just, okay.
Yeah.
So the Amplatz, we use a short tip Amplatz because if you have a long tip Amplatz, by the time you get to the stiffer part of the Amplatz, you have that 7 centimeter sticking out into the parenchyma.
Yeah.
And as we mentioned earlier, have a
perforation.
It causes perforation. It have like infarcts and so on. So there's an Amplatz which we call the short tip.
Yeah.
It's all about 2.5 centimeters of floppy.
Yeah.
So that's an important wire to have. Short tip Amplatz.
Amplatz. Okay. I got a question here. How do you know that you have retrieved most of the pulmonary emboli out? Do you let us say you work on it for 5 minutes, have a bit of venogram pulmonary artery inject to dye and see, or how do you know that you have got most of the thrombus out?
That's a good question. We don't go for perfection.
Yeah.
Like you don't have to go for what we call a squeaky clean.
Yeah.
You don't have. That's the body will take the rest of it.
Okay.
The criteria to me important is and especially if the patient, we go back again to the same thing. If the patient is under local anesthesia, the patient will give you feedback.
Yeah.
How it's going, many times I tell the nurse, shut the oxygen. So I know that patients are having probably oxygenating, we're putting 5 liters and we're barely oxygenating. And all of a sudden we find the oxygenation up to, 96%.
Yeah.
I told them, shut down the oxygen.
Yeah.
Shut down the oxygen, patient oxygenating at room air at 96. Second of all, pulmonary pressures.
Yeah.
If pulmonary pressure drops, that's another good criteria.
Yeah.
So between those two, I feel that I got, because remember, any procedure has potential complications. And the more you continue, especially when we spoke about the track where you have a catheter sitting there.
Yeah.
I want to go in and want to go out as fast as I can with the decent amount of cost.
That's a great advice. That's a great advice. Thank you very much.
And that's the reason why I always check it. Did this patient have chronic PE before or no? Because if the patient had PE before, then I know that the drop, I'll be working for a week and the blood pressure
will not come down. Yes, absolutely. That's a good lesson. Yeah.
So make sure the patient did not have chronic PE before. Any patient has no history, the pressure should drop. So if I couldn't get the pressure down, then there's a problem.
Yeah.
And of course, I inject contrast and see how much of it, and I see how the patient doing clinically. And sometimes we stop. Sometimes we just, you can't take the clot out and you have to admit failure. It happens very rarely, but we work a lot and we can't take enough clot out. The pressure is still high. The patient not doing well. But to me, after 30 minutes to 40 minutes, I'm done.
That's
Same as when I'm taking clot from the brain. If I can gain progress in 30 to 40 minutes, then that's time to stop.
And this is the crucial point when the intervention is to know when to stop. And this is very important because sometimes this limit is not there and you start at certain level, you are making more damage than benefit to the patient. This is again another very, very basic but also very important thing to remember when you go that beyond the 4 minutes, there is something wrong. You're not gaining here. So either you go back or think of another strategy. And this is very important. Yes, thank you.
I always remind people our oath in medicine.
Yes.
What's the first one?
Cause no harm. Not to cause no harm. Yes.
Before we benefit the patient, we need to make sure we cause no harm.
Absolutely.
So the patient came to my table alive. I want patient to leave my table alive.
Absolutely.
So no success is not that bad, but causing harm is really
Absolutely. I got a question here. Someone asking if he want to start to build a unit to have pulmonary emboli kind of retrieval service. Is ECMO an essential part? And which type of tool do you recommend for him to buy? Penumbra or other device? Which one have the shortest learning curve?
So ECMO is not important because we can have ECMO in every hospital. There are bigger hospitals where we have ECMO, but we have medium-sized hospitals which they cannot afford ECMO, they don't have ECMO. You still have to have a PE program on those hospitals.
Okay.
Why? Because that patient we transferred.
Yeah.
From your hospital to a bigger hospital might die, and you are better off taking care of that patient in your hospital without an ECMO.
Yeah.
So to answer the question, no, ECMO is not a criteria for you to start a program. I think any medium-sized hospital has to have a PE program.
Okay.
Even without ECMO. Obviously, if you have ECMO, it's a major center and it's going to make things, of course, more complete.
Okay.
The second question is...
which device do you think, Penumbra or which type of caster, which have the shortest, let us say, the shortest learning curve?
I use all of them. Obviously, at the time we were Penumbra when it was the only thing we had, and then when Inari came out, we switched to Inari, and now when Penumbra came with their Flash, which is 16, I switched back. So I keep switching. So now to me, I'm using personally, but like even some some of my interventions on my own group,
Yeah.
they still stuck with MRCS. They didn't go back to penumbra.
Okay.
But I personally went back to penumbra because I felt that I could use a 16 French and achieve the same thing that I would choose a 24 French.
Okay.
You could use the picture I have here right now. This is actually an Inari 24. So what I tell people, if you use a bigger device, it's not about device. So the device, you just have to know the interested. Like if you're driving a car, okay, and you're a good driver, you have been driving for 40 years. I'm excellent. You're driving Cairo. You guys are the best driver I've ever seen in my life. People like, okay,
yes,
but you're an excellent driver. But now I give you a truck. I give you a huge 18-wheeler. You know what I mean? Although you're a good driver, does not mean you'll be able to use
absolutely, absolutely
a big truck. So a big truck has its own technique. Like for example, if you have a long big truck and you want to turn left, you have to turn right.
Exactly. So the bulkier the device, the less maneuverability you will have, even if you are very skillful.
Exactly. It has nothing to do with the skill. You have to get used to dealing with the 24 French device, going through the hardware. It's a great device, and some of my partners today are using the 24 French, and I use a lot of 24 French. You just have to make sure how you could advance a big device, and I said, and so on. So they are all good devices.
Yeah.
As I tell people, I don't know if any sport you play. Say you play tennis, or you play anything. You can have 5 different rackets. Yes. Every time I throw a different racket, you have to get used to 2.
Yeah.
And play with it all the time.
That is your workhorse. Yes.
Any device you get, just get used to it and know the weaknesses and strengths of each one of them. So that's something for people to determine.
Yeah.
And every market is different. So all these devices are FDA approved, are good devices, and CE marked and so on. You just have to get used to them. It's very hard to be good at 10 devices at the same time.
Absolutely.
We are the busiest ER in the United States. We have one of the largest volumes we have. And I can use every single device in the market. So I confine myself to 2.
Yeah.
And you go back and forth in each one of them. So whatever device you have, just use it again and again until you figure out.
Exactly. I remember you told me that you like the penumbra caster because the amount of blood loss is less with the new sensor that they have, and that the tip of the caster is a little bit stiffer, and then you can get more thrombus out of it. Is that right?
Yeah, they call it the hypertube.
Yes.
So the catheter, the catheter sucks more blood. The Inari has the ability to circulate the blood back. So they have something called flow saver back to the patient.
Yeah.
Penumbra doesn't have that, but they have an algorithm in their computer. It's a computer chip, so that it's not the blood flow every time it withdraw blood.
Yeah.
Now they have the 2.0.
Yeah.
Which is still just launched in Europe and so on. The 2.0 has the algorithm even less blood. But to me, losing about 200, 300 cc of blood is acceptable.
Okay.
We recommend patients to go and donate blood. You know what I mean? So 200 to 300 is not a problem at all. And even with the flow saver, when it's hard to give all the blood back, and the quality of the blood, we don't know.
Yeah.
But I always accept that this patient going to lose about 200 to 300 cc of blood, regardless of which device, if it's Inari or if it's penumbra. That's the reason why I always look at the hemoglobin at the beginning.
Yeah.
If the hemoglobin is 7, then you got to be careful.
Yeah.
You got to get blood transfusion. Any device you're going to use.
Absolutely. That's a very good advice. Yeah. Okay.
But those are great questions.
Thank you very much. We had the really pleasure of squeezing your experience. I'm very interesting for the next coming series with How I Do It by Professor Fakhir Elmasri. We learned a lot, me and all my colleagues and all the follower. It's a great lesson to all of us with many tips and tricks that we all are going to use in the future, and hopefully we'll squeeze another How I Do It procedure in a couple of weeks' time.
Absolutely.
Okay.
Anytime.
Okay. Wish you all the best, and thank you very much for your time. Have a nice day.
Thank you.
Thank you. Bye-bye.